Hi, this week we are going to talk about social determinants of health, those elements that are in our environment or within us that affect our health outcomes, both individually and as a population. And as we talk about this topic, I think it's good to think about how our healthcare system in the U.S. is responding and needs to continue to respond to affect those determinants of health across vulnerable populations. I think that the definition by the CDC is a good one. There's several great websites out there that have information on social determinants of health, and I won't read all of this to you, but they make the point that these factors can be biological, socioeconomic, psychosocial behavior, or social in nature, and they have the 5 categories listed here that are generally used: biology and genetics, including gender and age, individual behavior. So sometimes, of course, we make ourselves sick, and we're going to talk about that a little bit. The social environment, so all of those people around us who affect us simply by their behavior, our own income level. The physical environment, crowded conditions or pollution, all those sorts of things, clean water. Health services, just access to basic health care, of course, affects people's health on a daily basis around the world. Certainly, this is not a new concept, and I thought this was kind of an interesting graph I pulled off the internet. I was looking for some fun ones, and there's several. This is from a study in Great Britain where they looked at professional or social class as correlated with people's mortality. And of course, the more educated and higher level of job position you have, the longer your longevity. Women are way out there ahead of men, which has been typical. So this study was actually where they looked at people's lifelines across 25 years or so through 1999. So definitely not a new topic. She and Singh look at disparities in health from a vulnerability point of view and looking at all these factors as to how vulnerable it makes one to various adverse health outcomes. And they have individual factors, ecological factors and individual factors, so the environment as we talked about, and also individual factors. And they list them into 3 different categories: predisposing characteristics, so race, gender, and where you live would be a predisposing characteristic. An enabling characteristics is your insurance status, so it's those variables that sort of help or hinder us in seeking good health outcomes, whether or not you're in a house, if you're homeless, or where you live, and so forth. And then the need characteristics are more individual health characteristics, the way they define them. So if we have a mental health diagnosis or chronic illness and so forth that affects our overall health. And then this sort of gives us a vulnerability rating and feeds into health outcomes on both an individual and across a population basis. And this is, again, not a new concept. There are many universities around the United States who have centers for vulnerability population research looking at health disparities, quite often found in nursing schools. Personally, I really like using an ecological model for looking at determinants of health. It's similar to the vulnerability model that we just looked at. This is from the Institute of Medicine, but it's based on Brafenbrenner's work looking at ecological models where you have the individual person at the center. So again, what are the sorts of things that we just come with, that we're born with, our genetics, race, sex, and so forth. And then the family that we live in, certainly affects our health. How healthy is the family for a child as they grow up? And then branching out from there, the schools, the neighborhood that that person attends, whether or not they have social support within that immediate neighborhood, perhaps YMCA after school things, whether or not they go to church, if they have parks where they can exercise and play or walk places, and then just working on out. And there's some policy implications in this as you get farther out in the ecological wheel here that all play into, of course, our overall health. Of course, I don't have to tell you all that historically our approach to healthcare for people has been very much a medical model and very individually based. Sometimes we look at the whole family, but for the most part, we focus on a specific disease and how it is affecting that specific individual. And this is actually from another book. I didn't come up with um, the silver bullet analogy here, but I think patients quite often in the U.S. are seeking that silver bullet that will stop the illness and give me that medication that will just stop it. And as a group of people, I think we do not want to look at all the other environmental factors, our own behavior and so forth, that are affecting our own health outcomes. And the time is very limited when we go to see a physician or a nurse practitioner for our care. So I know I'm preaching to the choir a bit here, uh, but in general, we're very disease oriented, or as Don Berwick says, we do a great job at rescue care, where we intervene with a lot of technology, particularly for heart disease and things like that, but not so great in terms of prevention and looking across a population. So this information is from the National Institute on Minority and Health Disparities, which was established in 1993. So again, this is not a new topic. And we now know that mortality, as we looked at before, decreases with every increase in income and social or occupational rank. And we also know that social advantage can lead to long-term stress, causing permanent organ damage, and lead to hypertension and those sorts of things. And that's called allostatic load, where and this term was coined, I think, in around the same time as the institute was founded by McEwen and Stellar, looking at the physiological consequences of chronic exposure to fluctuating or heightened neural or neuroendocrine response that results from repeated or chronic stress. And that does have an effect on our overall health. And we now have several studies that have looked at, for example, the effects of discrimination and perceived discrimination of people of color and their health, particularly hypertension among African Americans. There is a genetic component there. It's very complex. It's not simply due to stress, of course, diet, etc., but there is a stress component quite often. Similarly, we know that education and income affect health regardless of ethnic group, the ethnic group that you are in. U.S. college graduates live at least 5 years longer than non-high school graduates, so that just education in and of itself, for a variety of reasons, can affect our health very positively. And of course, race and ethnicity has an effect on your health. Whites are healthier than other groups at every level of education, doesn't matter what it is. To look a little bit further at racial discrimination and the effects on overall health, I just wanted to tell you about a study that I was involved in that looked at the effect of perceived racial discrimination, or what's sometimes called microaggressions. So those things that we perceive, we know they're there, but they're kind of difficult to call out. people's behaviors towards us simply because of our color. And this study was at the end of '88. By the time we pared it down, we had more kids, but in looking across three major groups, we had an Asian group as well, but it wasn't enough to really look at differences between ethnic groups. So we pared it down to these three groups: multiracial, European American, and African American. And I have to tell you that when we started examining this data, it really made me almost physically ill. There was such a significant difference in children's depressive symptoms and the anxiety that they were experiencing on a separate tool called the BASC. When we compared it or ran correlations between that and how they rated stigmatization and discrimination at school by other children or teachers. So very sobering results. What was also interesting is that overall teacher ratings of disruptive behaviors for African American kids were definitely higher, and also their ratings of those kids' ability and performance were lower across the groups. So significant difference between the three ethnic groups. So very interesting findings. If you're interested, I can send you the paper, but also very distressing because I think this was done in the Seattle and Tacoma area, and I think we think of ourselves as a very liberal, accepting place to live, and yet when you talk to people of color, they will tell you that on a daily basis they experience slights and discrimination. So moving on from things that we really can't change so much about ourselves, such as race and gender and so forth, to behavioral related choices that definitely affect our health. And we know what all of those are. Smoking is a big one, lack of exercise, substance abuse, risky sexual behavior, and diet. All of these, of course, are a big problem in the United States, and this is also from the CDC, where 70% of all U.S. deaths are due in some way to behavioral choices. And of course, I don't have to tell you that the U.S. has the highest prevalence and the most rapidly increasing incidence of obesity. And that, of course, leads to cardiovascular disease, diabetes, orthopedic conditions, and on and on. Although, interestingly, I will say that there are several developing countries that are starting to catch up with us, sadly. I've been in Tanzania a couple of times to do work as a nurse, and a colleague of mine who does research over there looked at the rate of diabetes. And as diets and economic status have gotten better there, they've also been exposed to much more in the way of Western processed foods and sugar, sadly. So the rate of diabetes is increasing in these outlying villages, surprisingly. Ben was very, very surprised at his results as he looked over the course of a couple of years and compared rates of diabetes in these tribes. So very sad that we are affecting the rest of the world in that way. And of course, our approach to obesity, typically in the U.S., at least historically, has been to focus more on the individual, to ask that person about family history, diet, their activity level, and so forth, and tell them, you need to eat better, you need to exercise more, perhaps referring to a nutritionist and exercise recommendations. And I know Group Health has an excellent program for weight loss that really is more comprehensive and involves more of a team approach as well. But in typical, I think, offices, it's at your annual physical where you get some good advice, and then that's about it. And of course, in extreme cases, we recommend bariatric surgery. And so looking at the larger family, what are the barriers for this family in terms of purchasing healthy foods, Are they able to go out and even walk safely in their own neighborhood to get exercise, and etc.?